Welcome to THY Vlog channel. Proper aseptic technique during surgery minimizes the occurrence of surgical infections. However, when infection does occur, the consequences can be dire. Antibiotics are used in surgery to help prevent and treat infection, but lack of basic understanding of antibiotic use leads to misuse, overuse, improper application, and creation of superinfections, all to patient detriment. The goals of this chapter are to introduce the basic concepts of perioperative antibiotic therapy and to offer guidance in developing an appropriate plan for antibiotic use in surgery. With the development of methicillin-resistant Staphylococcus species and other multi-drug-resistant bacteria, it is no longer considered acceptable to administer an antibiotic to every surgical patient. Furthermore, it has never been acceptable to use antibiotics to compensate for poor aseptic technique during surgery. Veterinarians must be diligent about when, where, and how antibiotics are being used in their patients. Appropriate surgical antibiotic use revolves around two concepts: prophylaxis and therapy. Prophylactic antibiotic use is the administration of antibiotics before contamination occurs, and only when there is high likelihood that infection could develop or when an infection would be catastrophic should one develop. Therapeutic antibiosis is used when an infection is already present and is based on culture and susceptibility testing whenever possible. Empiric therapy may be started based on expected contaminants while waiting for culture and susceptibility results. But wise empirical selection is advised because poor responses to susceptible drugs may occur when the contaminant was not susceptible to the first antibiotic administered. The decision to use perioperative prophylactic antibiotics to prevent infection is determined by an assessment of the risk of infection according to the length of the procedure, certain host factors, and the surgical wound environment. As mentioned above, prophylactic antibiotic use cannot offset poor surgical performance, such as excessive tissue trauma or faulty aseptic technique. After all, the mere presence of bacteria rarely causes infection. Alteration of local host defenses caused by the surgical trauma, i.e., local ischemia, is necessary for routine numbers of bacteria to establish a wound infection. Therefore, proper surgical technique in an immunocompetent patient undergoing a procedure anticipated to last for a reasonable duration forgoes the need for antibiotic therapy. Prophylactic antibiotics should be considered for any procedure expected to last longer than 90 minutes. Infection risk doubles for every 70 minutes the patient is in surgery. Prophylactic antibiotics should also be administered in any case where an implant, e.g. bone plates, synthetic mesh, polymethylmethacrylate bone cement, non-absorbable suture, is placed. Infection around an implant, at the very least, will delay healing, and at the worst will cause surgical failure. Examples of catastrophic failure include the need to remove implants after a total hip arthroplasty or amputation of a limb due to intractable infection at the surgical site. Implants promote formation of a biofilm that harbors bacteria and inhibits natural host mechanisms and antibiotic effectiveness. The only way to assuredly eliminate a surgical infection where an implant is involved is to remove the implant. Certain host factors, such as the presence of concurrent disease, very young or advanced age, or immunosuppressive therapy, may also increase a patient's assessed risk and prompt the use of perioperative antibiotics. For example, patients with diabetes mellitus or hyperadrenocorticism have impaired immune systems and are, therefore, more prone to developing infection. Very young and geriatric patients have immature or impaired immune systems, respectively, that may increase the chance of developing a postoperative infection. Chemotherapy, by its nature, suppresses the immune system. Any patient currently undergoing chemotherapy or that has recently completed an immunosuppressive chemotherapeutic regimen should be considered at high risk for infection at the surgical site. During surgery, care must be taken to minimize contamination of the surgical site and surrounding tissues to maximize the effect of prophylactic antibiotic administration. The environment around a surgical wound can have a profound impact on the risk of developing infection. Large hematomas or blood clots, necrotic tissue, and foreign objects, including surgical sponges, left at a surgical site inhibit host defense mechanisms and promote bacterial growth. Traumatized and devitalized tissues are unable to mount protective forces against infection and are often also hypoxic, thereby promoting both aerobic and anaerobic bacterial growth. Unless a wound has been made under controlled aseptic conditions, such as a planned surgical incision after antiseptic preparation, some contamination from the outside environment has likely occurred. Contaminated wounds can be converted into clean contaminated wounds through careful debridement of devitalized tissues and copious lavage, which may negate the need for antibiotic therapy altogether. In contaminated wound surgery, antibiotic therapy should be limited to perioperative prophylaxis, if used at all. Obviously, infected wounds warrant antibiotic administration to be continued post-operatively with therapeutic intent, meaning a daily course of administration until the infection is resolved. Most body lumens have a native flora. These bacteria often serve vital functions, such as aiding in digestion. However, these same organisms in the peritoneal cavity will lead to life-threatening illness. Controlled, surgical incisions into body lumens are considered clean, contaminated wounds. Prophylactic antibiotics are not warranted unless anticipated surgical time is 90 minutes or longer. Careful surgical technique to prevent gross spillage of luminal contents into the body cavities is essential. If luminal contents spill into a body cavity, the surgical site becomes contaminated and should be treated by removal of the spillage and copious lavage. Such spillage is not a reason to continue antibiotics post-operatively. As with traumatic wounds, contaminated surgical sites can be converted to clean contaminated ones through copious lavage. Antibiotic therapy beyond perioperative prophylaxis is not necessary and could even be detrimental by promoting development of resistant infection or by masking serious infection, such as peritonitis, thereby delaying prompt aggressive therapeutic management. Selection of which prophylactic antibiotic to use is based on the expected bacteria in the targeted tissue. The most common bacterial source for surgical wound infections, especially in orthopedic and neurosurgical procedures, is from the skin. Skin bacteria are typically gram-positive cocci, usually Staphylococcus aureus or S. intermedius. A second common source of infection is from fecal contamination. Feces contain colorectal organisms, such as enteric gram-negative bacilli, Escherichia coli, and anaerobes, Bacteroides spp. Whenever a body lumen is entered, prophylaxis should be centered on the typical flora of the lumen entered. Gastrointestinal organisms include gram-positive cocci, enteric gram-negative bacilli, and anaerobes. Airway organisms include gram-positive cocci, Staphylococcus spp, and gram-negative bacilli E. coli. Urogenital organisms include E. coli and Streptococcus spp, and are more likely found with urinary tract infection, pyometra, or prostatic abscess. Antibiotic prophylaxis is not recommended for routine, elective procedures involving the urogenital tract, such as ovariohysterectomy and orchiectomy. Normal flora of the liver include anaerobic organisms, as well as gram-positive and gram-negative aerobic bacteria. But hepatobiliary procedures may also be contaminated by organisms arising from the gastrointestinal tract. The most commonly used perioperative prophylactic antibiotic is cefazolin because of its effectiveness against the most common perioperative contaminants and its ability to penetrate most tissues of the body. Typical perioperative protocol is to administer cefazolin 22 milligrams per kilogram intravenously at induction, ideally 30 minutes prior to the skin incision, and repeat that dose every 90 minutes during surgery. Administration is terminated within 24 hours, preferably as soon as the surgery is finished, even if contamination occurs during the operation. All patients should be monitored for signs of infection, e.g. redness, heat, swelling, pain, purulent discharge, fever, poor doing, vomiting, anorexia, respiratory distress, body cavity effusions, in the postoperative period and treated accordingly. Colorectal surgeries carry perhaps the greatest risk of infection because of the high numbers of bacteria that live in this area. Preoperative preparation with oral antibiotics can help decrease the number of bacterial organisms within the colon. The most common oral antibiotic used for this purpose is neomycin, started 24 to 72 hours before the planned procedure at a dosage of 20 milligrams per kilogram every 8 hours. Intravenous prophylaxis at the time of anesthetic induction is typically used as well. Mechanical bowel preparation with enemas and intestinal cathartic agents are not recommended because, although they will reduce the amount of fecal material present, they also liquefy remaining fecal material and increase the risk of contamination from spillage. In order to work prophylactically, the antibiotic must be present at the potential site of infection before contamination occurs. For that reason, the selected antibiotic is administered intravenously 30 to 60 minutes prior to first incision, or roughly at the time of anesthetic induction, and then repeated based on the pharmacokinetics of the selected antibiotic. Prophylactic antibiotics are discontinued within 24 hours of wound closure, preferably at the end of the surgical procedure. Continuing antibiotics beyond 24 hours actually puts the patient at risk for infection. Animals with clean wounds that receive antibiotics other than a perioperative prophylactic protocol have higher infection rates than animals that do not receive antibiotics. If infection is noted during surgery or if sepsis is suspected, antibiotic treatment may be continued post-operatively pending culture and susceptibility results when available and adjusted according to patient response. Thank you for watching and see you again.